Ladies and gentlemen, thank you for standing by. Welcome to the Chronic Graft versus Host Disease Education and Support webinar, presented by the National Bone Marrow Transplant Link. At this time, all participants are in listen-only mode. A question and answer session will follow the formal presentation. You may ask a question at any time during the conference by using the Ask a Question feature on the left side of your screen. As a reminder, this conference is being recorded. It is now my pleasure to turn the call over to Jennifer Gillette with the National Bone Marrow Transplant Link. Jennifer, please go ahead.
Thank you so much, Kevin, and thank you all for joining us today. As Kevin said, my name is Jennifer Gillette, and I am the staff social worker at the National Bone Marrow Transplant Link, and I'll be facilitating your program today. Just so you are aware, this presentation is going to be recorded and placed on our website so that others can view this in the future. It will be on the site in about a week, and just in case you want to review it or share it with someone. And you may also contact us if you want slide copies. Today's presentation outline will go as follows. We will start with a brief introduction to the link, or NBMT link, and then Dr. Annie M. will educate us on chronic graft versus host disease for about 15 minutes. And then we will hear from a transplant survivor, Christie, on how he coped with chronic graft versus host disease. And the remaining of the time will consist of a question and answer period. And then we will close with future programs being offered. For those who may not be familiar with the provider of this event, we would like to take a moment to educate you about the National Bone Marrow Transplant Link. The mission of the link is dedicated to helping individuals and their families from diagnosis through survivorship. We work with patients, hospitals, cancer centers, and other organizations to reinforce and complement medical care by providing resources and support and education. If you have any questions about anything you're seeing today or products that you're interested in, or if you're looking for more support, if you see on the right side of this slide, you can contact either Peggy Burkhart or myself. Our emails are right there, and we're happy to assist you. We provide resources to help families navigate the transplant journey. We have our series that you're getting part of it today as a webinar, but we also have a telephone series with that. We have our Lunch and Learn programs, multiple webinar series that can be viewed online, our peer support mentor program for patients and caregivers, just in case you ever want to talk to someone who has been through it, and our Second Birthdays Recognition program, and resource books, materials, and referrals. We do have a wonderful graft versus host disease book if anyone is interested in receiving that. And we also have a guide with products that could be helpful for chronic graft versus host disease. Please let us know if you're interested in receiving this to discuss it with your physician. A special thanks to our webinar event sponsors today, the Insight Corporation, Pharmacyclics, the Meredith Cowden Foundation, the Leukemia Lymphoma Society, and our esteemed link partners for their continued support. This is just a reminder that today's presentation is meant to inform and support, but it's not intended to replace individualized medical advice. Before adding any new approach or treatment to your regimen, you should discuss with your healthcare provider to determine if that intervention is right for you. Now, without any further ado, I'd like to introduce you to our first speaker, Dr. Annie M. We are so honored to have you here with us today. Dr. M is an assistant professor of medicine in hematology and oncology at the University of Pittsburgh's UPMC Hillman Cancer Center. She has been on faculty and completing her fellowship there since July 2013. Annie has been heavily involved in medical education for residents and fellows. As a clinical researcher, she's been involved in the development of clinical trials targeting novel mechanisms in the treatment of acute myeloid leukemia and chronic GVHD. Dr. M also has a close collaboration with the Chronic GVHD Research Group in the Experimental Transplantation Immunology Branch at the National Cancer Institute, led by Dr. Stephen Pavletic. Her clinical interests also include development of a chronic GVHD and long-term follow-up program for the stem cell transplant program at UPMC. Thank you, Dr. M, so much for being here with us today.
Thank you very much, Jennifer. It's a pleasure to be here, and thank you all for joining on the call. I'm going to start by just giving a broad overview of chronic graft versus host disease. This is going to be, again, just a broad overview, and hopefully after that we'll leave some time for questions later for more specific questions about anything that I talked about or maybe didn't get a chance to bring up. So the outline of the talk today, I'll just briefly talk about, what is chronic GVHD and what are some of the signs and symptoms, and then get a little bit more into some of the principles of treatment, how we treat chronic GVHD, and some of the exciting novel therapies and clinical trials that have been coming down the pike. And like I said, we'll leave some time for questions at the end of today's webinar. So chronic GVHD, as many of you know, is really one of the major barriers of what would otherwise be a successful allogeneic stem cell transplant. This basically results from an immunologic reaction of the graft or the donor cells against the host. It's really a multi-organ disorder. It's characterized by basically a dysregulation of the immune system. Inflammation and fibrosis are key clinical features, and that can lead to impaired organ function. The incidence varies anywhere between 30 to 70%, depending on different risk factors, and the symptoms usually do present within 1 to 3 years after transplant, on average about 6 months, but we do see many patients who present with chronic GVHD beyond 1 year after transplant. In terms of risk factors, history of acute GVHD is one of the biggest risk factors. Other things are when patients or donors are at an older age. A female donor going to a male recipient actually is a risk factor. An unrelated donor or an HLA mismatched donor is also a risk factor. Fully matched unrelated donors are less of a risk factor these days, but still slightly increases the risk. And then using peripheral blood stem cells versus bone marrow stem cells also does increase the risk. The risk does decrease with things like T-cell depletion of the donor graft, a prophylaxis regimen called post-transplant cyclophosphamide, which we use with haploidentical or half-matched transplants, and then umbilical cord as a stem cell graft source. So this is a slide that I actually borrowed from Dr. Pavletic in the NIH. Just kind of gives an example of a typical patient with chronic GVHD, although I will say that there are no quote-unquote typical patients with chronic graft versus host disease. There are a variety of organ manifestations that can occur, and patients can have one or many, and I really believe that each patient is unique and different. But this gives some examples of organ manifestations that can occur, and we'll go into more detail in the next several slides. So in terms of skin, there's a lot of different skin manifestations that can occur with chronic GVHD. There can be a rash, there can be kind of shiny, dry skin, change in pigmentation in some areas, and then something that we call sclerosis or thickened or tight skin that can occur. Sometimes there's areas that can look like it's almost like cellulite changes, or it's actually thickening of the tissue that's underneath the skin. There can be nail changes, such as brittleness, nail splitting, or even nail loss. Hair thinning or hair loss that can occur even after hair has recovered after chemotherapy or transplant. In terms of mouth, this is a common area that's involved, anywhere from just mild dry mouth to things like mouth pain, oral ulcers. People can have sensitivity to certain types of foods like cold foods, spicy foods, even toothpaste. And some patients can have limitation in mouth opening where there's kind of a tightening or thickening of the skin around the mouth. In terms of eyes, this is also a common area that's involved. People can complain of dry eyes or feeling like eyes are very gritty or sandy. There can be excessive tearing from that and sometimes even eye pain. Genitalia, this is an area that I think is under discussed. I think, some patients are hesitant to maybe report this, and quite honestly, I think physicians don't do a great job of asking everybody about this. For women, it can be anything from vaginal dryness to having specific lesions, chronic GVHD lesions, scarring, or even some stenosis, which is kind of narrowing of the area. Men can have things such as narrowing of their urethra or even lesions on the penis. And because the tissue is similar in the oral cavity as it is in the genitals, it can often be associated with oral graft versus host disease. In the GI tract, this also can cover a wide spectrum of symptoms, things like nausea, diarrhea, decreased appetite or weight loss that's unintentional, bloating or cramping or intolerance to certain types of foods, and then difficulty swallowing can sometimes occur from narrowing of the esophagus. In the liver, people won't necessarily complain of symptoms, but we can see abnormalities in the liver function tests. And in the lungs, people can complain of shortness of breath with activity at rest or even cough, decreased stamina with activity. The muscles, joints, and fascia is another common area, so tightness of joints, limitation in range of motion of joints. People can complain of muscle cramps commonly in the hands or in the legs, and joint swelling can also occur. So again, that was a pretty broad overview of all the manifestations that can occur, some more serious than others. This is just a snapshot of some of what are the most common initial presentation of symptoms, but when you look at over the whole course of chronic GVHD, things like musculoskeletal, like the muscle and joints, also becomes more common, as well as the genitalia. So I know that one question had come up about how GVHD can evolve over time, and it certainly can and does evolve over time. And so what may present initially may not be what is an issue later on in the course. So in terms of treatment, I want to talk a little bit more in detail about this. Now, first just talking about some of the principles of our chronic GVHD management, I will say that having a specialized chronic GVHD or a long-term follow-up program in your transplant center is a really great resource. I really do believe these are needed for focused but comprehensive care in this very unique disease. Usually does require a multidisciplinary team approach, so not just the transplant physician or the oncologist, but having specialists for some of these specific organ complications who are also familiar with seeing GVHD, which again is a rare complication. I think that's a really important feature. There are specific and very comprehensive guidelines that do exist for surveillance and screening for people after transplant, or specifically for people who do have chronic GVHD. And so those are great resources for us who see patients with chronic GVHD. And as I mentioned, subspecialty expertise may be required for some of the specific organ sites, because some of the things that are involved in the treatments are not just what we do, which is systemic immune suppressants, but also specific local therapies, organ-directed therapies, and supportive care things that only subspecialists can do. As I mentioned, there are some specific guidelines that do exist for recommended screening, preventive practices, and also ancillary therapy and supportive care, things that are specific to certain organs. Unfortunately, we won't have time to go over all of those in detail, but these are the two references that cover those pretty comprehensively. And again, these guidelines are specifically for based on survivorship, so people who are survivors of transplant and patients who have chronic GVHD. So this slide I just put in just to show you that the biology of chronic GVHD is very complicated, and so there's a lot that we are still trying to understand about it. But we're doing a better job, and because of that, I think we have some exciting treatments that have been coming along that I'll talk about. So right now, what the standard of care is, first let me mention that the median duration of treatment is going to be long. It's about 2 to 3 years on average, and some people do need treatment even beyond that, sometimes even more than 7 years for a small percentage of people. So, that's something to know, just to have patience with it. Chronic GVHD is a chronic disease, as the name suggests, but it's not something that hopefully is a forever process. There is this idea that chronic GVHD burns out, and so eventually there is an immunologic tolerance that develops. And so, most people should not need immunosuppression forever. In terms of our treatment goals, there are several. So certainly we want to help people to live longer. That is a goal in all of our treatments. But more specifically in chronic GVHD, trying to stabilize or hopefully improve specific organ manifestations or complications is another really important goal. So, hopefully we always, aim for improvements, but sometimes even just stabilizing and preventing things from getting worse is a huge achievement for us. We also want to try to limit the long-term toxicities of the treatment, specifically for steroids, but certainly some of the other things that we do. And that is a very important goal because, as I mentioned, people may be on treatment for several years. And then also extremely important and high priority, and something we shouldn't forget about, is just trying to improve quality of life, how people are feeling, how they're able to function in their day-to-day. So all of these are important goals. So in terms of the standard of care right now, the first-line therapy is steroids plus or minus an additional immune suppressant agent called a calcineurin inhibitor, which might be something called tacrolimus or cyclosporin. About half of patients will respond to this and be able to just require this. Unfortunately, half of patients do require some second-line treatment. And here there really is no standard of care. So there's lots of options, things that you may be familiar with already, and there really is no right or wrong answer. It's just a very individualized decision in terms of what would come next. Prevention is also an important thing to talk about. So, again, there's no standard of care here, but there's a lot of research that you should know about that is going into trying to prevent chronic graft versus host disease. I think, as I mentioned, there are a lot of organ-directed therapies that do exist, and this is really important, I think, specifically for quality of life, functioning day-to-day. There are a lot of unique organ-specific treatments that are out there as well. Just so you know, some of the factors that go into how we decide which treatment, specifically second line, we would choose. Certainly the organ involved in the severity or any coexisting medical problems would help us in our choice. Risk of infections is a pretty common side effect, but some may have a different risk. There are some important drug interactions that need to be considered. How often the drug needs to be monitored is also a consideration. And certainly I think physician comfort or institutional practice is a pretty common factor in terms of deciding on a treatment. And then very importantly, treatment accessibility in terms of distance to a transplant center, how often people need to come and follow up, and cost and insurance coverage and things like that. And then I think also most importantly would be the patient preference in terms of deciding between some different treatments. This is a pretty long list of therapies that have been reported in some fashion beyond the first line. As you can see, there's quite a long list of options. And again, the factor, how we decide, it depends on all those different factors. There's only one agent that is approved for chronic GVHD by the FDA, and that's BrutonTip, and I will talk a little bit more about that. And I will say that we've come a long way to be able to say that we have one agent that's approved for chronic GVHD, because before this, there were none that were FDA approved. So even having one is I think, a pretty huge milestone. So, there really is an unmet need. As I mentioned, there's only one FDA-approved agent for chronic GVHD, but really we should have more options than that. And so there's a lot of work going on behind the scenes with research to try to achieve that. There are many clinical trials that are available now, and I think these are really important to try to understand, what of all of these therapies is going to be the best option for people, if one exists. Lots of new drugs are being developed in oncology in general, but a lot of those are being used in chronic GVHD, targeted therapies that are less toxic, and again, a lot of research going into prevention as well. If possible, I think enrolling in a clinical trial is really the best option if it's available. There have not, in the past, been as many options available for this, but I think now, pharmaceutical companies are understanding the importance of studying this, and so a lot of studies are becoming a lot more national and widespread. This is a busy slide that just basically is showing you what all the different areas of research that are going on. So the ones that are highlighted in red are just some of the ones that are a little bit more advanced in terms of where they are in their development. But just so you know, there's lots of activity going on in trying to find targeted therapies. So this is a table that shows you most of the trials that are going on right now, clinical trials for chronic graft-versus-host disease and where they might be occurring. And again, this is a little bit of an older slide, and things are changing all the time. And I'm going to show you a reference of how to find the most up-to-date information on this. But this, again, just shows you some of the newer targeted agents that are being studied and where they're being studied. Most agents that are being studied in chronic GVHD, I will say, are already agents that have been developed in other diseases, in other either oncology diseases or even sometimes autoimmune diseases. And so quite often we already have experience with these drugs, which is nice. So one of the novel therapies that's in the clinic, and as I mentioned is FDA approved, is a BrutonTip. This is what we call a B-cell pathway inhibitor. So it's actually an agent that we use very commonly in a lot of B-cell malignancies, lymphomas, and certain leukemias. In a clinical trial in chronic GVHD, it did show an overall response rate of 55% in people who had already multiple lines of therapy. There are some side effects to the drug, such as fatigue, diarrhea, some bruising, and then serious but more rare side effects including infection, atrial fibrillation, which is a heart arrhythmia, and even a bleeding risk. But this is, like I mentioned, FDA approved and is actually also ongoing in some clinical trials to look at it as in other settings aside from just steroid refractory chronic GVHD. Another treatment that you might see more commonly in the clinic these days, which is not FDA approved as of yet, is an agent called Ruxolitinib. So this is actually ongoing in several phase 3 clinical trials for both acute and chronic graft-versus-host disease. It's an agent called a JAK inhibitor, so this is something that we use in a disease called myelofibrosis. But agents such as these are also being used in a lot of autoimmune diseases. The clinical trials are ongoing, but there have been a lot of retrospective studies or experiences with this drug that show a pretty impressive response rate. Now, we'll have to see what shows from the clinical trials, because that will give us the best data in terms of what the response rates are. But we're all pretty excited to see what that data is. Some of the common side effects are bone marrow suppression, so low counts, and also infectious risks that, this is going to be a risk with almost any treatment for chronic graft-versus-host disease. And as I mentioned, there are lots of other JAK inhibitors that are also being developed and studied in GVHD, but also other diseases. Agents that you might hear of called Itacitinib or Baricitinib, which are also being studied in clinical trials. So some of the national clinical trials that I'll just highlight, because these may be more available widespread, because they're industry-sponsored trials that are being looked at nationally. So one is looking at that drug that I just mentioned, Ruxolitinib. It's a randomized controlled trial, so that means that you would either be put on the treatment arm with Ruxolitinib versus what we call best available therapy, which is what your physician would have chosen for you otherwise. And this is for patients with chronic GVHD who have had steroids and need something additional. There's also a study ongoing using a BrutonTip, the one that's FDA approved, in combination with steroids for first-line treatment of chronic GVHD. And this is to see if maybe people can get off steroids more quickly and maybe get better response rates as well. And then there's another national trial that should be opening very soon, which isn't quite open yet, I believe in most centers, but should be opening very soon, which is looking at a different JAK inhibitor called Itacitinib. And again, it's a randomized trial in combination with steroids, again, as initial treatment for GVHD, again, for the goal of trying to get off steroids more quickly and trying to get better response rates. I wanted to list the resource of clinicaltrials.gov, which is something that anyone can access online, and you can search for clinical trials in chronic graft versus host disease and search for trials that may be in your area, search for other things, some of the other drugs and trials that I've mentioned, and that's a great resource. I will also wanted to highlight a trial that's ongoing at the NIH or the NCI that some of you actually may be familiar with. It is a study where patients are able to come for a very comprehensive evaluation. It's actually done over 4 days, where you have evaluation by oncologists who are specialists in chronic GVHD, but also a lot of subspecialists who are, again, very focused both clinically and also in research in chronic GVHD. So a very impressive evaluation. And what they do is they come up with recommendations individualized to each person, and then give those recommendations to the patient's physicians from home. Really is incredible. I've been a part of these evaluations, and I really do encourage people to pursue this if you are able. It is free of charge. They provide funding for travel and things like that. And this is, you can look up on clinicaltrials.gov, but there's also contact information that I listed below for Dr. Pavletic, who is the chronic GVHD expert and also the primary investigator for this trial. So just to end on some take-home messages, GVHD really is a chronic illness. You know, again, it's going to take time to manage. Some of the damage may be irreversible, but not all of it. And it does eventually, the process does burn out. So please have patience, even though I know it gets hard and I know it gets very frustrating. You're not alone. Please remember that. Many of the things that you're experiencing are common among transplant survivors. And so if you don't know any, seek them out. There's lots of resources that we've already talked about, and some that I'll list at the end. Again, the NIH is also a place where people have come just to find people who are very familiar with some of these complications. The goals of treatment, as I mentioned, are to really try to control the clinical manifestations, try to prevent any worsening, and then importantly to improve quality of life and limit toxicities of the treatment. And having a long-term follow-up or a chronic GVHD program really can help to address many of these barriers to some of the survivorship care. So some other messages. So early intervention and compliance are important to prevent serious outcomes. So keep that in mind. Be sure to tell your doctor about anything or everything that you might be concerned about, and don't feel like it's not important or maybe something mild. Certainly discuss any concerns. Ancillary care, supportive care are really critical to help decrease the treatment-related toxicities and improve quality of life. These are, I think, important components to our treatment, not just some of the systemic treatments that I mentioned. And again, unfortunately, don't have time to go over all of those in detail with this talk, but lots of great resources that you can find some of these ancillary cares. And then, I want people to be realistic about expectations for the new normal. Don't set yourself up to be disappointed. Don't think that life goes back to normal immediately. Again, it takes time. Have patience. Some of it is just adjusting to what is the new normal, and that's okay. Again, we just want people to feel better, to feel good, and to be able to have as much of their pre-transplant life as possible, and whatever we can do to get to there, we will do that. There's lots of work that's ongoing from the research point of view as well as clinically, and seek out as many of these resources as you can. Chronic GVHD is a rare disease, and seeking out resources, people who've been through what you've been through, or physicians who are familiar with this is really really important. So, and again, enroll in a clinical trial if that's available to you. These are some of the resources that I just wanted to list. You're aware of some of them, I'm sure. We already talked about the National Bone Marrow Transplant link, which has great resources online. The books that Jennifer mentioned are really incredible. I use them all the time in my own clinic. There's also some nice fast fact sheets for supportive care for some of the specific organ complications, the ancillary and supportive care that I mentioned, that's available on the NMDP website, and then some other great guidelines that are listed here. So that's all I have for now. My email is listed if you do have any questions and want to reach out after this webinar. But now I will take it back to Jennifer.
Oh, Dr. M, thank you so much. The level of specialization you bring here and to share that with others, I know there's many people really benefiting from this today, and we are very grateful for you joining us. And now I'd like to introduce everyone to our next speaker, Lou Christie. Lou has been a survivor of AML for 4 years and has had 2 transplants in March and September of 2014. He is thriving after transplant, which some would have said would be difficult at the age of 71. He is a very active volunteer at the National Bone Marrow Transplant Link, serving as a peer mentor, blogger, and speaker. And he continues that great work with the Leukemia and Lymphoma Society, as you can see in this picture here. Thanks for joining us today, Lou.
Thank you. Good afternoon. I would like to thank Peggy and Jennifer for the opportunity to share my journey today, from my diagnosis to my current GVHD condition. I was diagnosed with leukemia, AML, acute myeloid leukemia, in December 2012. I was 71 years of age at that time, and it seemed like a devastating diagnosis with a worse prognosis. In fact, my oncologist, the first one, told me that take a vacation for a year because that's all you have left. And I couldn't handle that at all. I had to try to do something to stay alive. So I was treated with a regimen of light chemo, receiving blood transfusions and platelets for a 14-month period. It was suggested that I should consider a bone marrow transplant since they weren't sure that the chemo regimen would still be effective after 14 months. They weren't sure there were any studies about that. So I would like to talk a little bit about a life message. And once the storm is over, you won't remember how you made it through, how you managed to survive. You won't even be sure whether the storm is really over, but one thing is certain. When you come out of the storm, you won't be the same person who walked in, and that's what this storm is all about. Now, I believe this message strikes home with me and everyone else who has had a bone marrow transplant and also has graft versus host disease. So after my diagnosis and treatments, I didn't know how I made it through them. And I was sure how effective everything was, and was it really over? And I am certain that I am not the same person I was before all of this. So my first storm was 9/11, prelude to leukemia. I really believe that being at 9/11 caused my leukemia. And right now I'm currently under evaluation by the World Trade Center Health Organization to certify that my leukemia was caused by my being at 9/11. You can see from the top picture that was from my office window. And then if you look at the pictures below, I was there at right after 9/11, and you could see from the picture on the right that that's what I was breathing in every single day. I would come home with a sore throat, red eyes, sore nostrils, and that consisted because I was there for a year right afterwards, every day. So a little bit of history. As Jennifer said, I was diagnosed 2012 with leukemia AML. And on March 23, 2014, I had a bone marrow transplant from an allergenic donor, stem cells taken from his hip, given as a transfusion, and I did not know the donor. On September 24, 2014, I had a second bone marrow transplant because the first one failed after 5 months. And I was on treatment for transfusions and platelets from that time to my second transfusion. And I got a transplant from my younger daughter, which was a haploid identical transplant called a haplo, and she gave me peripheral blood. And the reason they call it haplo because she was 50% of me and 50% of my wife. However, the match for the 50% was 100%. Of the 50%. And what she did was she had to come into the hospital and be hooked up to this machine which synthesized her blood. And it had different vials where the blood went into. And they took her stem cells, which they gave to me, and the other parts of her blood were put back into her body. So my initial graft versus host disease manifestations, I had rashes, unbelievable rashes all over my body. Coughing, I couldn't stop coughing. I had GERD, gastroesophageal reflux disease, and that was probably one of the worst things I had because my chest would tighten and my arms would go numb. And this happened often during the day. I also had hardening of the skin on my hands and feet. And I had exfoliation of skin on my entire body so that the hardening of the skin on my hands and feet would peel off in big pieces, and the exfoliation were little pieces of skin falling off my body. In fact, my wife one time thought it was sand on the floor, but it was really skin cells. I was easily bruised. Just touch me and I bruised, and I got big black marks. I had night sweats, and if anybody knows what that is, I'd wake up in the middle of the night. It was like I took a shower in my bed. I had muscle cramping in my legs. I had neuropathy in my feet, where I couldn't feel my toes, or it felt like there was cotton in between my toes. And fatigue was terrible. I could hardly even walk. But then my eyes, that was a problem too. They were oozing, and they were dry, and they were very uncomfortable. So what was the treatment? Now, the reason I put this slide up was everybody's different. No one's going to have the same types of medications that I had. And one of the things that happened after my first BMT Link webinar, we formed a support group. And there were about 10 or 12 of us that got together and talked about what we went through. And one of the things that was always asked, what medications are you on? And everybody was different. Because nobody's the same. And this was tailored for me. So I would think that your oncologist would give you something completely different than what I have, or maybe some of the same medications. So you could see from what the different medications did and how they helped react to whatever condition I was having. These are my current GVHD symptoms. I have a lot of peeling on my head, and the skin comes right off, and that hasn't stopped. But the peeling on the rest of my body has stopped. I still have easy bruising, and once I get that big black mark on my arm from bruising, I get skin tears, and the skin comes off and I bleed, but that goes away after a while. In my eyes, I went to my eye doctor, and he told me that I was getting a cataract in one of my eyes, and that I probably should consider having a cataract surgery. So I did. I had 2 cataract surgeries, and my eyesight has improved to where it was like when I was 20 years old. I have perfect eyesight. I could read everything. So that was one of the best things I did. But my eyes are still oozing. Every morning I have to wipe them, and every night I have to wipe them as well. Then I also had surgery for a basal carcinoma on my cheek. And then I also had surgery for a squamous cell carcinoma on my arm. And my dermatologist told me that that was very unusual to get a squamous cell on your arm, but I did. And I think that was from being in the sun, both of those. And one of the medications I was taking, I went to a dermatologist in New York City who specialized in GVHD, and he told me one of the medications I was taking actually caused my skin to turn color, turn brown, the pigmentation changed. But that's slowly fading as well. I still have neuropathy in my feet, just in my toes, which is strange, but I do have ulcerations in my mouth. And one of the things I have a problem with now is my esophagus and swallowing issues. If I don't take small bites and chew very well, the food actually gets caught in my throat. And a few times when I was out to dinner, I actually thought someone would have to do the Heimlich maneuver on me because that's how bad the food got caught in my throat. I also have tinnitus, and I'm not sure whether that was a result of GVHD, but I have a constant hissing in my ears. So how do I cope with life and GVHD? What I just discussed may sound daunting. However, being positive is my main means of overcoming this disease. I do the following things to keep me grounded. I exercise. I was a runner. I ran for 35 years, but I don't run anymore. Now I exercise. My wife and I walk. We try to take 10,000 steps every day, which really is important for us to do. because I couldn't even walk 3 steps when I first came out of the hospital. I have regular visits to my health providers, and I think that is so important. I go to my oncologist every few months. I go to my dermatologist. I go to my eye doctor. I go to my urologist, because I think that's important, because you have to look and see what's happening with your body, and then you got to figure out, should you schedule a visit, and I do that religiously. I also socialize with friends and family frequently, and that really helps, because they are the greatest support I can imagine. I also join groups to see how others cope. There was a group at the hospital where I was transplanted, and I also joined a group from the Leukemia and Lymphoma Organization, which was really beneficial because there was an active group. We did various things. We went bowling, we did art, we did Tai Chi, always something different, but we always walked at the beginning of every session. And what Jennifer had mentioned, I also do peer monitoring with the MBT link, and also with another group called Immerman's Angels. I think that's important for giving back, because it makes me feel really good to do that kind of thing, to speak to other people that are either contemplating a bone marrow transplant or have GVHD, and I just listen to what they say and try to be supportive. One of the things I like to do, my wife works 3 days a week and comes home at noon, but I like to cook. So I always like to try new recipes and looking at different cooking shows, and that helps me too. I also listen to a lot of audiobooks. I try to listen to a book every month on all different subjects, mainly history, mainly biographies, and some science fiction. I also attend Light the Night walks every year, and these are amazing. These are held in a park, and there are thousands of people that attend. And what they do is they have survivors, and they have presenters, they have food, and we walk with lanterns. And they have 3-color lanterns, 3 different colors, for survivors, for caregivers, and for patients. And it's a really uplifting experience to go there and do that every year. I also, what I didn't put in the slide was, I attend a Celebration of Life dinner, which my oncologist sponsors, because she has done at least 400 different bone marrow transplants, and all the survivors come to that. So it's a very, very, very nice thing and very uplifting to do. It's a sit-down dinner, and they have dancing, and it's a chance to speak to other survivors. And even Peggy, I had Peggy invited, and she attended one of those one year. One of the important things also that I do is I watch where I go, I watch what I eat, and I avoid crowds. I'm very careful about that, because it's important that I don't come in contact, because I still think my immune system is compromised to some point, even though I've been through all of this. So I'd like to just tell you what another message that I live by. Challenges are what makes life interesting, and overcoming them is what makes life meaningful. And that's, I guess, a picture of the back of me as a survivor, which I got from the Light the Night walk. So again, everything I've told you so far, I try to remain positive about. If this is the worst that I have, I could live with that. Just being here every day is so important to me, just to associate with my family and live a full life as much as possible. So thank you for allowing me to present this. So Jennifer, I'm through.
I'm so sorry. I thought the mute button was off. Anyway, thank you, Lou. As always, you never cease to inspire us. And I just thank you for being a part of this program today. Okay, we will now start the question and answer period part of our program. I do want to remind you that the questions we address during this time do not serve, or they serve as medical recommendations only, and no individual medical advice can be given. But it looks like we have quite a few here for Dr. M, so we will start with her. The first question that I see here is, can GVHD manifest itself in different ways, affecting different areas over time?
Yes. So as I mentioned earlier when I was going over the symptoms, the GVHD can really evolve. And so what people may have initially may not be what they have a couple of years down the line. And what's active at first may not be active later, but a new problem may arise. So it is sort of an evolving dynamic process. And unfortunately, very hard to predict in terms of what organs might be involved or what might resolve or what might come up later. That is one of the challenges that we have. And if we knew that information, we would be a lot smarter. But unfortunately, it's not predictable.
Thank you. What about, are there long-term benefits of GVHD in terms of long-term remission and survival?
Yes. So something I didn't mention is that having a little bit of GVHD is actually potentially a good thing. We do know that having GVHD, acute or chronic, does decrease your risk of the relapse of the underlying problem for which you were transplanted. So we know that the relapse rates are lower with GVHD. But ultimately, because GVHD itself can lead to complications and impact survival, those things do eventually cancel each other out. So, right. So so there are some benefits, but ultimately, we don't want GVHD, but perhaps a little bit of an immune response is a good thing.
Okay, great. What about one person writes, are there any holistic things that are recommended or options for steroids in the treatment of GVHD?
Right, and that's a good question. I think that's always something that people are interested in. There's not a lot of data that we know about in terms of things that might help with complementary or holistic options. But I always think that's a good thing to pursue. We actually at our center have an integrative oncology clinic that focuses on just those types of treatments, whether it be acupuncture or Reiki, immunotherapy, medical marijuana. And so I do support people pursuing those as long as it's not in place of what they're already getting. But I think those are always great additions for people if it does help symptoms.
Okay, great. What about?
Oh, I'm sorry. Can I just mention one more thing, Jennifer? Sorry to interrupt.
Sure.
Another thing I should mention that's specific to GVHD patients is also massage therapy. I've had patients really benefit from that when they have thickened skin issues, joint issues, cramps, and things like that. So that's just another, one of our complementary therapies that I should mention.
Oh, great. Well, we have a nice long list for you. Lots of people have questions for you today. What about one person writes, how can you tell the difference between side effects from chemo and GVHD?
Yeah, that's a great question. It can be hard to tease out sometimes. I would say the timing is probably going to be the most helpful. If there are side effects that have occurred right after chemotherapy, then and linger even through GVHD, that's probably for the chemotherapy. But things that have resolved that come up as new, I would point to GVHD. And sometimes they can be even similar side effects, but it's really just the timing that probably makes the difference.
Okay. Getting to some more of these here. Are there, excuse me, are there any studies that are promising for lung GVHD and its impact on quality of life?
Yeah, that's a great question. Lung GVHD is certainly a challenging area. It is one of the more serious manifestations of GVHD, and we do try to screen people. So for those of you who don't have lung GVHD, if for our survivors and for our patients with GVHD, you should be getting regular pulmonary function tests to try to screen for this before symptoms occur. a lot of our systemic treatments do treat lung GVHD, and not until recently have we had any treatments that are specific for lung. But just recently, one thing that there was a study for is something that we call FAM, or FAM. It stands for fluticasone, azithromycin, and montelukast. And those are basically, montelukast, another name for that is Singulair. And those are basically 3 treatments that help decrease inflammation in the lung. They're actually used for other things. So fluticasone is inhaled steroid, and that comes in other names or other forms. Azithromycin is an antibiotic, but it actually has anti-inflammatory properties in the lung. And then Singulair, or montelukast, is also an anti-inflammatory for the lung that's used in other lung diseases. And there was a study specifically in people who had GVHD of the lungs that when we used this, it did help stabilize the lung function. Some people did improve, but for the most part there was stabilization, which again is sometimes a big achievement, because one of the difficult things about lung GVHD is that when it does get severe, it is hard to reverse. So we do try to be on top of it, catch it early, treat it early as much as we can. There's another treatment that is in a clinical trial at the NIH, something that I was actually involved in developing. It's a drug that's called a neutrophil elastase inhibitor. It actually doesn't even have a name yet because it has not been approved for other indications, but has been studied for other lung diseases. And that study is still ongoing. So for people who may be interested or are able to pursue that's also an option. Just anecdotally, we have seen that people have had improvement in their symptoms and sometimes some improvement in their lung function. But again, we're seeing stabilization as well. I will also say that in terms of some of our ancillary care and supportive care, things like pulmonary physical therapy, pulmonary rehab that is specific for lung patients, that has helped people in terms of functioning, quality of life, and things like that. So pursuing some of those things are important as well.
Great. Why is the range of incidence rates so large with the range of 30 to 70%?
Yeah, that's a good question too. So it's a couple of different reasons. So one is that the risk of GVHD does differ with different types of risk factors. So depending on the risk factor, the risk may be a little bit different. But it's also that these are ranges that are taken from a history of studies at a time when GVHD wasn't as well defined. It was more subjective based on the physician, and so it wasn't until 2005 when the NIH consensus criteria came out, which is basically it was a group of experts from around the world who came together and developed specific guidelines for diagnosing and studying and treating chronic graft versus host disease. And it wasn't until that standardization that people were all speaking the same language about GVHD. And so part of that is also because in the past it was just more subjective. So we don't know the exact incidence. It's probably somewhere in the middle there, around 40–50%. But again, that's going to really depend on specific risk factors.
Okay. I'm so sorry. And another question we have here, and please, I apologize if I am pronouncing any medications incorrectly, but if someone initially presents with fairly serious chronic graft versus host disease and high-dose steroids are required, are there any reasons why a physician would hesitate and not add tacrolimus to the steroids?
No. So I'm sorry, Jennifer. The question was, is there a reason why tacrolimus wouldn't be added to steroids for treatment?
Yes.
It just depends on, again, the individual patient and the risk factors for things like infection, or tacrolimus can have other side effects, such as kidney side effects and things like that, blood pressure and things like that. So it just depends on what side effects the person might be experiencing. The reason that we do add additional agents in addition to steroids sometimes is, again, just to try to limit the course of the steroids, or to try to be able to get people off of steroids faster, or to be able to get them on a lower dose. So it doesn't necessarily make response rates better in the GVHD. It just helps people get off steroids, which can have its own side effects.
Okay. Now, this one, I think I know what you're going to answer, but I'll ask it just to make sure. How long after an allergenic MUD transplant do you recommend a patient stay on tacrolimus?
Well, that depends, again, on whether or not the person experienced GVHD. It depends on how well they're doing as they're tapering the tacrolimus. So there's no specific right answer for everyone. We do try to start tapering it after about the 100-day mark if people are doing well and don't have any GVHD. But how quickly that's tapered, again, depends on different risk factors or how the person is doing, or even how the physician tends to taper. But there's no set guideline for that. And that may be longer depending on if the person did experience GVHD or experience any GVHD symptoms as it's being tapered.
Okay, great, thank you. Another person here writes that they'd like to hear a little bit more about what kinds of things are done for swallowing issues. They said that they seem to have air in their esophagus, which makes swallowing difficult, and also air in the stomach, but not in the intestines. Any thoughts on that one?
Well, certainly in terms of the swallowing, and I actually wanted to mention this too after Lou had brought it up, is that sometimes, as I mentioned, that there can be tightening of the esophagus, which can make it difficult to swallow. And if that's the reason that it's difficult to swallow, then sometimes gastroenterologists or GI doctors can go in and just dilate the esophagus. So they go in as they would for an endoscopy, and they are able to dilate the area. And I've had some patients who do this, who have to do this periodically just to kind of go in and dilate it again and again, but really does help with the difficulty swallowing if that's the reason. Sometimes people have pain with swallowing, and that can be just from irritation of the tissue that's there. That's a little bit harder to treat, and sometimes what we can do is do kind of pain coating with pain medication to some extent. I'm not familiar with the air in the stomach. That sometimes can be, if it's sort of a bloating or intolerance to certain foods, that can occur. And again, sometimes what we can do for that is even try to using steroids that kind of coat the stomach, which sometimes can help with some of the GI symptoms from chronic GVHD, things called Entecort or beclomethasone.
Okay, thank you. What about one person had heard Lou talk about his tinnitus. Is that typically something seen as a GVHD symptom?
Not typically, but I will never say never with GVHD because I think we've seen just about everything with rare symptoms, but not typically. Sometimes that can be a side effect actually of chemotherapy long term, but again, that's hard to say. I will also bring up something else that may be a question for people that Lou also brought up, which was neuropathy. Neurologic manifestations of GVHD are more rare, but they do occur and can manifest as things like neuropathy. We don't treat them any differently. We can treat them with similar treatments that we use for GVHD. Just anecdotally, we have had some success with some patients using treatments like IVIG, which is an IV immunoglobulin, or rituximab, which is one of the treatments we use for chronic GVHD sometimes. Or steroids. But these are linked to GVHD for sure, some of the neurologic side effects, just a little bit more rare, so may not be as discussed as much. And, again, no specific treatments that we have for it, but we treat it similarly to GVHD.
And I have one more question for you, Doctor. I have one person here who wrote, could you review what impact GVHD can have on the liver? And this person's also wondering why there aren't more transplant centers using T-cell depletion if it lowers rates of GVHD.
Yeah, both good questions. So with the liver, GVHD can affect the liver, same way that acute GVHD can. And again, patients don't necessarily have symptoms from this, but we will see abnormalities in the liver function tests. So things that are called AST and ALT or the bilirubin levels may rise when we do lab work. And not something that patients would necessarily feel or experience symptoms with. But that definitely is a manifestation of GVHD. Another thing, and then you had mentioned the T-cell depletion, so that's also a good question. Unfortunately, with everything that we do that improves the risk of GVHD, it also increases risk of relapse. And so this is always a balance that we are battling in transplant in general. And we are still in search of the Holy Grail, which is that ultimate balance between preventing GVHD and preventing relapse or treating the disease successfully. And so the problem with T-cell depletion is that it does increase the risk of relapse of the underlying disease. There's also a higher risk of graft failure, so the stem cells never taking it all. So rather than doing a full T-cell depletion, there's some research that's going on now about trying to take out cells, the T cells that we think are specifically the culprits of GVHD, while leaving T cells that will still be important for preventing relapse. We actually have a study that's ongoing right now at our center at the University of Pittsburgh that is looking at one of these strategies of just depleting certain types of T cells that seems to be very successful, actually. So that's something that we may see down the line.
Great. And Dr. Annie, again, we just thank you so much. Having you on this call is like having Google for GVHD.
Well, thank you so much.
You just know so much, and I appreciate you being here to help us, and I thank you, Lou. Just so everyone knows, we do have some wonderful upcoming programs. If you would like to register for those, on October 9th, we will be hosting a webinar on all things finance. We know that there are many issues that can come up with finances during this journey, and we will have a wonderful lawyer from the Triage Cancer Center helping us with that, as well as we also have our next Lunch and Learn program on Wednesday, October 17th, and we'll be focusing on how to navigate and advocate for yourself and your loved ones on this transplant journey. A special thanks to all of our esteemed link partners who we would not be able to do all that we do without them. And we invite you to take a quick survey at the end of this webinar. If there's anything we can do in the future to make these programs more relevant to you or to improve them, we would greatly appreciate that feedback. Thank you for joining us today. We hope this program was helpful, and we wish you all a great day.